Good morning, everyone, and welcome. Welcome to the first NACOS Education Forum, as Jam said, introduced us just a minute ago. My name is Atlantis, and I'm honoured to be the founding president of the National Association of Clinical Obesity Services. This is the first collective of clinical obesity services in Australia. And I'd like to, on behalf of NACOS, thank Novo Nordisk for sponsoring this entire event. And I'm sure that by this evening, all of you will agree that it was an incredibly worthwhile initiative. As you will see in the next few slides, NACOS is rapidly asserting its legitimacy as the peak organisation driving improvements in access to clinical obesity services and raising standards in clinical obesity care. But first, to emphasise the moral issues associated with obesity, I ask that all of you participate in the following thought experiment called the Veil of Ignorance. So to begin, imagine yourself in an original position. So you're like adult thinking, conscious beings, sometime before birth, and you're floating around the stars, looking down on Earth behind a veil of ignorance. So behind such a veil, you know nothing about your ethnicity, your gender, who your parents will be, where you will live, which social class you will have, what society you will live in, and so on and so on. So behind this veil, all of you are simply equal. And you would expect a natural and fair distribution of advantages and disadvantages in life. However, you do know that where you end up living really matters. Look at the worldwide prevalence rates for obesity for 2016. The chance of having obesity in adulthood appears to be a bit of a lottery, and this is more so today than ever before. Back in the 70s, you had a much lower and more equal chance of having obesity, regardless of where you ended up living. This is because obesity rates have tripled in most countries since then. So back then, for example, you had a 1 in 10 chance of having obesity in Australia, whereas now you have a 1 in 3 chance. So these simple descriptive statistics, so trends, can help us understand factors that may, or perhaps more importantly, may not, have caused the rapidly rising rates in obesity worldwide. So for instance, let's consider a whole range of individual risk factors which have been implicated in the global obesity pandemic. I'm sure that all of you are familiar with these and more. Now, while it's clinically important to have a better understanding of these individual risk factors for stratifying, prioritising patients, for tailoring your treatment plans, for developing new and more effective pharmacotherapies, it is implausible that any of these risk factors played a major role in the worldwide, or a major role in the rapid population-wide increases in body mass index and the tripling of obesity rates since the 1970s. There is no evidence of mass exposure of these risk factors on entire populations, which would have had to have occurred consistently across countries, at appropriate time points before and during this period. For example, let's consider genetic predisposition. All right? One of the individual risk factors that has been the subject of a lot of research over the last decade or so. And this is one of the most recently published examples from the Hunt cohort. Investigators studied over 67,000 participants from the general population in one region in Norway, whom were followed up since the 1960s. They then divided the entire cohort into 5 equal groups based on their genetic risk score to compare the highest with the lowest genetically predisposed groups. And genetic risk score was calculated using all but one of the 97 single nucleotide polymorphisms known to be associated with body mass index using standard methods. So apart from an observed dip in the 80s, mid-80s for women, the prevalence of obesity increased consistently, both among genetically predisposed and non-predisposed groups, across age and age categories for men and women. So clearly, population-wide changes in BMI have occurred during this period, regardless of genetic predisposition. More plausible causes of the global obesity pandemic include a whole range of factors that affected entire populations since the 1970s. There is good evidence that societal changes occurred during this period, which have likely resulted in population-wide increases in food consumption, especially from energy-dense and nutrient-poor foods. So it is the transition to obesogenic environments within societies which likely explain the population-wide changes or the worldwide changes in body mass index, and also explains the differences between countries in the current rates of obesity. So obesogenic risk factors likely explain differences in obesity rates between populations from decades of weight gain. Individual risk factors likely explain obesity rates within populations, so where one of your patients would sit on the national body mass index distribution. And it's the interaction between obesogenic and individual risk factors which help explain differences in obesity rates within the global population, so where one of your patients will sit on the worldwide BMI distribution. It's disappointing and frustrating to see a lack of accurate information in the public discourse about the causes of obesity and persistent blaming of individuals for having obesity. And in my opinion, it's the stigma of obesity is propagated by individuals who are either consciously or unconsciously are ignorant about the plausible causes of obesity. As a result, the stigma of obesity is pervasive in Australia today, as it is in most societies in the world. There are approximately 6 million adults living with obesity in Australia. Approximately 1 million of those are currently living with clinically severe obesity, most of whom have complex healthcare needs requiring multidisciplinary team care and support. When it comes to treatments, there is very limited access to adequate clinical obesity care in our health system, as it is elsewhere in the world. Only 4 pharmacotherapies are approved for obesity management, weight management, and none of those are currently subsidised. There's a range of diet replacement products available, effective, beneficial, none of those are subsidised. Very limited access to allied healthcare professionals per calendar year. And my understanding is that there is confusion among some GPs about whether or not specific Medicare subsidised items to access allied healthcare professionals can be used specifically for obesity or weight management in primary care. There's a very small number of public hospital clinical obesity services nationwide, and I think this number is conservative. And less than 10% of weight loss surgeries in Australia, based on estimates from 2014 and 15, are publicly funded. And this scenario is even worse for individuals living in socially disadvantaged communities. So in the real world, there seems to be an unfair distribution of advantages and disadvantages, which likely determines your chances of both having obesity and accessing treatments. And these inequities, I believe, are what motivated us to form NACOS. And as you can see, our vision is to live in a society that provides timely and equitable access to the best available care for the effective management of obesity and its complications. And as you will see in the next few slides, NACOS is leading a broad program of activities to realise this vision. But before I do, I'll present a few brief slides on our evolution, which has been rapid over a very short period of time. A small number of us came together and formed the Clinical Obesity Services in Public Hospitals Working Group in the middle of 2017 to address two issues, two aims. First, to describe the current state of clinical obesity services in public hospitals for adults in Australia for the first time. And two, to develop a set of recommendations to address current resource gaps and future needs based on consensus of expert opinions. And the COSIF Working Group originally had expert representation from 15 public hospitals as well as a range of other stakeholders. The findings of that research were published in 2018, and my understanding is that it has been a useful report to clinicians for building greater advocacy for their own service, their own clinical obesity service within their organisation and beyond. In October, later that year, a few of us in the COSIF voted to formalise into an organisation. In December, we received a small establishment grant from Novo Nordisk, and we quickly moved to engage external secretariat support to help us with all of the tasks required in becoming an incorporated association. Some of those tasks you can see there, including to build and maintain our website. And as many of you know, by March we launched our website and logo. At this point, I'd like to acknowledge our friends from the NADC, and in particular their CEO, Ms. Natalie Wisher, as well as Professor Stephen Colagiuri, for providing us with expert advice early on based on their 25 plus years of establishing the NADC. So that was really helpful to me and to several of us formulating NACOS. In May, we received a grant from Novo Nordisk to run this, our first education forum, and as Jam suggested, that it's the start of many more to come, and that was a commitment that everybody heard this morning. Thank you. And in June, we received a small grant from, a grant from Novo Nordisk to undertake a quality assurance program or project, and the primary aims of that project are to benchmark outcomes across services within our health system. So we are currently seeking to leverage that grant, and we've submitted an application to a third party, to Western Sydney University, for a partnership grant. And if successful, that will enable us to broaden the scope of that study and to develop a decision aid for clinical obesity services I'm calling this DACOS for obvious reasons. And essentially that will be a computer software program providing visual feedback to simulate what-if scenarios to help healthcare professionals and patients make better informed treatment decisions based on algorithms from data from the real world services. And in July, I promise this is the last grant I'm going to be talking about from Novo Nordisk. Well, maybe not, we'll see. We received a grant from Novo Nordisk to develop the first national framework for clinical obesity services, and I'm really excited about this project. So that grant has enabled us to commission the PwC to facilitate this work. And the purpose of the NACOS framework is to provide the first guidance on how to most effectively design, deliver and access clinical obesity services in our health system for a range of stakeholders, healthcare professionals, patients, consumers, health insurance industry and health policymakers, etc. This project commenced several months ago. It's progressing extremely well, and we are now conducting a series of workshops and meetings and surveys to help us build a consensus among the stakeholders on the content of the NACOS framework document. And I anticipate launching the reports by November, December this year. I do hope that all of you found my brief summary of our activities and our achievements informative and useful, and that it clearly demonstrates our strong commitment to improving, that is, access to services and raising standards in clinical obesity care. I think we at NACOS believe that these activities and those that we are currently planning are important vehicles for achieving this goal. If you haven't already done so, please go to our website and apply to join NACOS on behalf of your service online, because at the end of the day, the future and relevance of NACOS really is entirely dependent on us having a broad and nationally representative membership. I hope that my welcome has set the scene for the whole forum, and I have one last thing to play for you, which will complement hopefully my welcome address.
What's the hardest part of living with obesity?
The feeling that I'm being judged, whatever I choose to eat.
That nagging sense that I'm an embarrassment to my kids.
Stares and people who stare.
The look of dread on every passenger next to an empty seat.
That first glance that tells me I failed the interview before it's even started.
Knowing that I just don't fit in to the seats or life in general.
Wondering if I'll ever feel comfortable on a beach.
The fear that I won't be around to meet any grandchildren.
Actually, the hardest part of living with obesity is people thinking that I brought it on myself.
I wish everyone understood.
It is so much more than eat less and move more.
Obesity is a complex disease.
Not a life choice.
Let's help change attitudes.
Let's lose the weight of stigma.